Ladies and gentlemen, good afternoon. Welcome to the Toshiba Symposium. My name is Patrick Brouwer. I'm the moderator of this session, and I also am the first speaker, so that's the reason why I'm here and not over there. There are some questions I have to ask because of the organization. It's whether you can turn off your cell phones, please, and fill out the questionnaires for the accreditation, which is really important, I think. Okay, so let's first start off with this Neuro Symposium with a presentation on the Aquilion ONE, one of the new systems that has been on the market and that has a real change, brought a real change about in the neuro imaging. But first, we have to look at where we came from, because the first CT scan started with a boy band. Is there anyone in the audience who knows which boy band was responsible? The Beatles, exactly. Because the Beatles brought in so much money for EMI records that EMI could put all the money into research for the CT scanner. And that's what they did. So they made their first clinical usable system in 1973. And this was put into clinical operation in 1974. Then there were 60 systems. And the first images, they were, well, we would say terrible. If this is what you have to report from, you would say, okay, I go back home. But in those days, it was magnificent work. So we made a giant leap, and from single slice imaging we went to helical imaging, and also multi-slice combined with helical imaging. And in 1998 we had the multi-row detectors, the 4x2, and that went to 320 times a half a millimeter detector in 2007 in the Aquilion ONE. And what we learned from that is that we can basically image larger volumes than we originally anticipated. We can image 16 centimeter in one volume at this time. So where did all this technology take us? From these images, these plain X-rays, to this. A lot of information in the images. Of course, at a cost, but I'll get to that later. But except for the additional data and the nicer looking images, we also got faster imaging, because imaging the heart is less than 1 second. And even if you want to do the whole body scan, it will take you about 6 seconds. We were really happy in 2008 to be one of the first hospitals, and in Leiden in the Netherlands we were the first in our country to have the Aquilion ONE installed. And originally it was installed for the cardiology. And we neuroradiologists are vultures, so we thought, okay, they have a nice tool, let's just get there and use it. So we used it for all kinds of neuro applications. For example, imaging of right maxillary sinusitis. We can do a 14 centimeter volume scan in half a second. And if you compare it to the older 64 slice Aquilion, and you looked at the radiation dose, you can see that even the radiation dose is halved. And the quality is still good. And also for ear imaging, a 4 centimeter volume scan in 1 second. And of course the post-operative spines, where there is all kinds of material in there. And you can see in the lower image nice 3D reconstructions to impress the clinicians. And the neuro applications also went to imaging of the blood vessels, of course, stenting of the carotid, whether the stents were still open, and the patent stent is readily recognized on these images. And then the question is, it's nice, this Aquilion ONE, but is it really that special, and is it that expensive that we should use it? Yeah, I think it's expensive, but only if you don't use the full potential. And I think this drawing shows that if you don't know how to use it, then you need to put a lot of money in to finally get to what you want. So in neuro applications, the benefit was not only from the 16 centimeter volume, but also from the dynamic images. This fish was scanned by Professor Bloom in France, and he had this fish in a mug that he put in the CT scanner. We didn't get informed consent, but I think the fish was okay with it. And it makes doctors and patients laugh, this system. And you can imagine that you can look at functional imaging here for the temporomandibular joint as well. And this is an image where the patient flexed, retroflexed the head and swallowed. And if you look at the image on the right side, you can see that you rotate the image while you still see the dynamic sequence take part. So how about dynamic imaging in neurovascular pathology? That's basically my main interest, being an interventional neuroradiologist. What we did with neurovascular images is that we looked at morphology and we looked at hemodynamics. And the hemodynamics, of course, is catheter angiography. There's nothing that beats it. It's the gold standard. But with the Aquilion ONE, we get to the point that we may have an alternative. This is an image. The whole brain is scanned in real time, and you see contrast in the arterial phase coming into the brain while it's scanned, the parenchymus phase, and then the venous phase. And as long as you keep on scanning, you can image whatever happens in the brain. So we use this quite a lot in a research setup. And how we do it is we give the patient a timing bolus of 10 milliliters of contrast at a rate of 5 milliliters per second. And we scan during this contrast injection to see when the arterial phase kicks in, when the venous phase kicks in. And then we can adjust the protocol, the start and the end time of the protocol. So after the bolus, we get a mask image. That's this first green column. With high quality, 300 milliamperes. And later on, as the arterial phase kicks in, so for example at 15 seconds, we get a continuous scan at a lower dose for a longer period of time. And that renders us pictures like this. So this is a dynamic contrast imaging on a CT scan. And it looks like a catheter angiography, but all arteries at the same time. So we call it dynamic CTA or 4D CTA or time-resolved CTA, whatever word you want to name for it. You can use it to look it up in the publications. But not only this dynamic imaging to get the arteries, but also for physiology, this Aquilion ONE is really a nice machine because we can do perfusion CT imaging of the whole brain. It's the same 50 milliliter of contrast that we use for the whole sequence of the CTA. So basically, there's no additional contrast agent needed. And what we do is we have the normal imaging, and then we add some slices in the end just to have a longer period of time to look at the perfusion imaging. And these are the images you get, whole brain perfusion that you can look at from all kinds of directions. So basically the Aquilion ONE for me is the all-in-one. I think it sounds more or less similar, and it is similar because we can do almost anything we want with neuroimaging on this machine. Whether it's morphology or the hemodynamics or even physiology, we can make it work. For example, our stroke imaging protocol is based on normal CT, non-contrast, to exclude a hemorrhage, which you can see here. So we know the patient will not get IV RTPA or thrombolysis in the CT scan room. And then we do a CTA afterwards. With the CTA, we can see where there is a problem, if there is a stroke due to an obstruction. And we can also see if there is a pathway that leads us there, so we can do intra-arterial treatment or not. And perfusion imaging, of course, maybe for some prediction. It's really difficult because there's a lot of research going on and there's still no final answer whether this has a lot of value. But what information does it bring? Well, physiological information about the cerebral perfusion, that's clear. But also information about the infarct core and the ischemic penumbra, so the potentially viable tissue. And information about microcirculation on tissue level, so if the autoregulation of the brain is still intact. And why do we need a large volume? Well, we want to establish the size of the infarct because that's of importance for the prognosis. And what we know is that if you change the size, so instead of 16 centimeter with the Aquilion ONE, we have some images here of 8 centimeter, 6, 4, and 3 centimeter area that we looked at. If you are going to look at the infarct size, you will underestimate it. And some publications already showed that with the smaller volume, in 28% of cases, an additional, or with a larger volume, 28% of cases, you will find an additional infarct. And in 24% of stroke patients, you will find out that at the level of the basal ganglia, which is the target area with the 4 centimeter detector, the basal ganglia region is normal in 24%. So in a quarter of the patients, you will actually miss the infarction. So we did a pilot in our center. So all the patients that we saw an infarction on the Aquilion ONE in the 16 centimeter volume, that's the one on the right with the 100% penumbra, infarct core, and ischemia detection. Of those patients, we also did a reconstruction to 8, 6, 4, and 3 centimeter slabs. And then we looked how much do we miss. Well, if we have a 5 millimeter slab, we will only detect 5% of the infarct. And that goes up to about 80% in the 8 centimeter, but you can see that it's still a lot of difference. And this is an example case, an 82-year-old female. She had a 2.5 hour onset of stroke. And well, basically the perfusion imaging didn't show anything abnormal at the basal ganglia level. But if you go higher up, you can see here in the time to peak and the mean transit time that there's a prolongation. And in the CBF, you can see a restricted area there. So is this the golden standard, the CT perfusion? Well, I don't think so, because there's a lot of validation that we still have to do. I mean, 90 milliliter per 100 milligrams of brain tissue per minute. It's really difficult to assess that quantitatively on the machine. In a way you can, but there are a lot of pitfalls. And the problem is that the vendors have different thresholds and they have different ways of displaying the results. So what should we do? Are there any alternatives for this? Of course, you can do MR, but that's difficult in an acute setting and it has some contraindication, but it has a high signal-to-noise ratio, which is nice, and it has information on the acute ischemia as well. And one of the good things is it has no radiation. But I think with the CT, we can eventually get a good result as well. What we should do is look at the trials that are going on now, like in Holland, the Mr. Clean trial and the DUST trial. In those trials, we will get information on the outcome of the patient, the outcome of the treatment, and their baseline perfusion imaging. And maybe we can find predictors. And one of the things that we have to look out for is image post-processing. It should not be directed at creating nice images for the public and for the clinicians in the hospitals, but it should actually give us physical information that we can use in treatment decision. We do get combined information, so that's the good thing of the CTA. We get CTA and CTP in the whole brain, and this nice image. And in our system, it's 9 millisievert radiation dose. That's because of our experimental setup. Normally, you would get 5 millisieverts. So we looked at the morphology and the physiology, but we wanted to see whether it could replace catheter angiography. So can it do something with hemodynamics? Well, if it can replace it, it depends on what we want to achieve. And there are a lot of things that we want. We want to reduce the contrast dose, risk reduction of the catheterization. We want to make it more available. And the question is, at what cost do we want it? We can do the imaging for aneurysms, for fistulous lesions, but in aneurysms we only look for morphology. Fistulous lesions we will look at the dynamic imaging, and in vasospasm we will look at morphology, dynamic imaging, and physiology. So if we look at aneurysms, what is the additional value of the right-sided image where there is a movie playing, looking at all the arteries going there? Is it better than the left side where we already can see what the aneurysm looks like? I don't think there's a real benefit, except if you want to plan the treatment and you want to know if all the branches are open. But basically you can do that on a morphological image of the CT as well. But it has additional features. You can look in an axial plane. You can basically turn the whole volume around while there's contrast going up. But in fistulous lesions, I think there is a real difference, because AVMs and pial and dural AV fistula, these are lesions that are really difficult to find on MR or CT, and you need a catheter angiography to prove that they are there. But I think it's going to change, because this is what it looks like on a normal CT. On the left image, you see hemorrhage, and you see some vascular structures, but it's really difficult to say whether it's an artery or a vein. You see some calcification, and which is which. It's really difficult. And also on the MR, it's difficult. What is nidus? What is a dilated vein? What is a pouch? Which one is an intranidal aneurysm? That's really difficult. So basically, we only have 3 questions in these kinds of pathology. That's, can we diagnose it? And can we recognize all the important features that we need to see? And can we decide on a treatment modality? And that's what we have to look into with the Aquilion ONE. And then, of course, is the quality sufficient? But that's all 3 questions together, I guess. What we look at is the early venous filling. Here is an artery filling an early vein, whereas the normal parenchymal blush is not there. So we know this is an AVM in a normal catheter angiography. That's something we have to look at, early venous filling. But also, what kind of vein is used for the drainage? Is it the deep venous drainage, or is it superficial venous drainage? All kinds of things that we can now appreciate on the dynamic CTA. And there are a lot of things that we have to look into if we want to make diagnosis, but that will go way beyond the topic of this presentation. So I'll point out to this paper in radiographics in 2010. That's a really nice paper about it. Or you can join one of the neurovascular imaging courses that we throw in Leiden. There's one on May 16th and 17th, and also one in October, where there's one day on brain perfusion and one day on 4D CTA imaging, and then we get into all this kind of details. So basically we wanted to know, is the quality sufficient? Well, for example, this angiography, what you can see here is a occipital artery with a transmastoid artery going to the transverse or sigmoid sinus, causing a fistulous lesion where there is filling of the vein in this area. And you can also see the middle meningeal artery going in this direction. And of course we want to know, can we see the same with the 4D CTA? Well, basically we can. This is the occipital. You can also see the occipital on the opposite side. That's a negative point. But still you can see the transmastoid branch, and you can appreciate the middle meningeal. And this is what it looks like if you make the run play as a movie. And if you want to look at the venous structures, no problem. All the venous structures that we can find on the normal angiography can be found on the 4D CTA as well. And we compared all those images. We had a subset of patients with AVMs and fistulas, and that we had a look at to see how they compare. And our initial results showed that from the dural AV fistulae, out of the 11 that we found on angiography, we only found 10 in the 4D CTA. And I will show you why we missed this one in the 4D CTA. From the AVMs, all 17 AVMs were found with the 4D CTA as well. The classification in the dural fistula was totally in accordance with the angiography. For AVM, there was one difference, which was not a major difference. We did find a lot more feeders on angiography than we did with the 4D CTA of dural AV fistula. So we found 8 more feeders in 10 AV fistula that we did not discern on the 4D CTA. And with the AVM, that was in 3 of the 17 cases. And this is basically due to the non-selective injection of contrast. First, I'll show you why we missed one of the dural fistula. This is the patient who had a bleed, and you can see the 4D CTA here. And basically, this area showed a real slow flow. Because of the mass effect, there was already hemorrhage, of course, present. And the very slow flow and the small feeders made that we could not discern this by the 4D CTA. And then get back to the non-selectivity. What's the problem if we just give contrast by the arm? The problem is that we don't know which artery is where. This AVM, we thought that the feeding was from also from one of the perforators, the lenticular striates from the MCA on the right side. But basically, when we did a vertebral injection, we could see that this is the artery that the arrow is pointing to. It is contributing, but it's the posterior choroidal coming off of the right posterior cerebral rather than from the MCA. Did this information alter our decision on therapy? No. The discrepancies were not important, or they were not yet important, because all the things that we missed, we will see during catheter angiography. And that's most of the time the treatment that we are going to do anyway, or work up for radiotherapy. So are we done? No, I don't think so. We have the TREX trial in which we are going to look at a lot of things. For example, can you determine treatment results, and can you do follow-up imaging? For example, this patient who already had an embolization of this AVM, you can still see that there's an early venous draining here. And so that means that for follow-up it might be really interesting. Here you see the early venous filling through the AVM before the rest fills. So follow-up of an AVM can be really nice with 4D CTA. So what can we conclude? I think that 4D CTA is emerging as the first possible alternative to catheter angiography, and especially in patients with a low suspicion or contraindications for catheter angiography, I think we should try to use it. So how does it compare? We know that the spatial resolution is a problem, the temporal resolution is a problem, and selectivity is a problem. But it's really readily available, it's non-invasive, and you don't need a lot of trained personnel to do it. And the costs are lower as well. So we should improve it, and improvement always has a cost. So it's a trade-off between the signal-to-noise ratio, which we want really nice, and the radiation burden on one side, and the rotation speed of the machine at the other side. The rotation of the gantry of the machine is 1/3 of a second, so you get actually 3 frames per second imaging. You can do more reconstructions, so for example you can make a reconstruction of 0.1 second time difference, but it means you use back projections and stuff, and the thing is that within 1 second you actually create 10 slices, but one slice is actually a brain volume. So you have 10 volumes already in 1 second. So after 15 seconds, you can imagine how much data that is. And the computer is not capable of calculating that at the moment. Another thing is the radiation burden. It's the signal-to-noise ratio improvement. There are several publications on new technological developments where people make algorithms that they can use to get the pictures in a better state for us to look at them. And then radiation dose. Yeah, radiation dose is really important. It's pretty hard to see for you what the difference is between the pictures. But basically, if you're behind a real nice screen, you will see the difference if the radiation dose goes down. But we have to look out, because in 2009 with the CT scan there were several problems in the United States. And in West Virginia in 2011 there was a hospital that seriously over-radiated patient suspected of having strokes with the CT scans. And this was more than a year after federal officials alerted the hospitals nationwide to be especially careful in those types of imaging. So this patient still had the same problem. And this is not something that comes with newer machines. This is something that we in the past had as well. In the ECR meeting here in Vienna in 2004, there was already a presentation of Imanishi who showed 3 cases. So is doses a problem? Yeah, maybe it is. If we look at the chest X-ray, it's a 100-time-fold increase in dose. But then again, you get so much more information that probably it's worth it, and it's way beyond the level that you think is acceptable. CT scan, brain CT, 2 millisieverts, no problem. Abdominal CT is 10 millisieverts at this moment. The cardiac and full body, 2 to 5 and about 20 millisieverts. And the 4D CTA perfusion, if you do it in the way that Toshiba installed it on the system, it's 5 millisievert. If you do it in the research setting that we use in our hospital, it's higher. And if you compare this to catheter DSA, the radiation dose is about 2 millisieverts. So if you do one total session of catheterization and include a 3-vessel 3D, you get up to 8 millisieverts, so that's pretty comparable. You don't have the physiological information, but still. So it's higher, but still below the acceptable limit and without the inherent risk of angiography. So what I think we can conclude about the Aquilion ONE is that whole head CT imaging is possible. Dynamic vascular imaging with IV contrast can also be done. Non-invasive imaging, although we have angio-like characteristics, CT-like spatial resolution, and low-dose CT-like contrast resolution, and then a temporal resolution of about 1/3 of a second. So we think it's a leap forward, and with we I mean the team that I like to acknowledge here. It's the group from Leiden and the group in Toronto that we do our research together with. And if you're still not convinced that this is a nice tool, it may be really nice to create Christmas cards for you. And with that, I would like to thank you for listening. And of course, I'm open for all kinds of questions.